Good afternoon, everyone. I'm Hao Huang, Associate Professor of Social Sciences, and welcome to the Illinois Tech Social Sciences Great Problems, Great Minds seminar series. For this seminar, so you can submit the questions during the webinar by typing in the chat box. We will open the floor to the question at the end. Today's speaker, Dr. Brice Newbold, a professor in the School of Earth, Environment, and Society, and Associate Dean of the Faculty of Science at McMaster University in Hamilton, Ontario. He received his PhD degree and the bachelor's degree in geography from McMaster University. He has held guest scholar positions at the Center for Comparative Immigration Studies, University of California, San Diego, 2004, and the Medical Research Council's Social and Public Health Sciences at the University of Glasgow, 2008. A position which included a fellowship through the Department of Urban Studies, University of Glasgow. He worked at the University of Illinois Urbana-Champaign between 1994 and 2000. Before returning to McMaster in 2000, trained as a population geographer, his research interests include health, immigration, aging, and mobility, and transportation. He has published scholarly articles on these research areas in top journals such as Social Science and Medicine, Epidemiology, and Journal of Transport Geography. His work has been supported by the National Science Foundation, Social Sciences and Humanities Research Council, Canadian Institutes of Health Research, and Social Sciences Research Council. It's great pleasure to welcome Professor Brice Newbold.
Thanks very much, Hal. Great to be here. Thank you very much for the invitation. So I do want to spend some time this afternoon. I hope everybody's enjoying afternoon. It is Friday. But I want to spend some time this afternoon talking about some of the research that I've been involved in from a group perspective. And I saw Yuri join in. Hi, Yuri. Great to see you. And spoiler alert, you've probably seen or heard this presentation before, I believe. Anyhow, what I'd like to talk about this afternoon is some of the work that I've been involved in, a team grant funded out of McMaster University here, looking at or assessing older adult mobility using wearable technology. Just to give you a very brief outline, I'll provide you some context to the work that I'm engaged in. So some of the aging societies talking about what we mean by mobility and how that connects into health. I'll introduce the work that we're doing and the study that we're doing, the McMaster Monitoring My Mobility, or the MAC-M3 study. Its research objectives, the testing and the validation of the technology that we're using, and then some of the mobility indicators that we're getting from the data before providing a few concluding thoughts. So several years ago, I gave a presidential speech at the annual meetings of the Western Regional Science Association. And during that, I asked, okay, well, where's the population research within regional science? And so regional science, of course, is a collection of academics. Could be drawn from economics, geography, planning, or related studies, and really sort of looking around and saying, well, where is this, and why isn't it being looked at more closely? Because we certainly see from a global context an aging population. It seems that it wasn't that long ago that we were more concerned with runaway population growth and overpopulation. That's really no longer the concern now, as we start to see population growth slowing And in some countries actually reversing, where we're seeing shrinking societies, shrinking population. China, for example, being one country that has recently sort of turned that corner and is now reporting a shrinking population. But several countries in Europe as well are experiencing shrinking population that's reflective of, one, very low fertility levels, so below replacement fertility levels. And to be replacement fertility is considered to be around 2.1. We're seeing fertility levels that are lower than that in many Western countries, but not just exclusively Western countries. The other piece where we're seeing this aging population is because of extensions to life expectancy and declining mortality rates, for example. And so, as I said, we're seeing that not just within Europe, for example, or North America, as we can see here, but in multiple countries. Africa is still on an upward trajectory, but that will probably start to peak very soon, while other countries have either slowed that population growth, or other regions, I should say, here have either slowed population growth or starting to level off. From a Canadian perspective, our most recent census, which was done in 2021, we saw that the average age of the Canadian population had increased from 41.2 years in 2016 to 41.7 years in 2021. And the proportion age 65 and over, and we generally, of course, use 65 as that dividing point between the labor force and an older population. So we see that proportion increasing. In 2016, it was nearly 17%. By 2021, that last census, it was 19%, and it's projected to reach about 23% of our population by 2031. We're also seeing an increasing share of the old, so older adults that are age 60 or 85 and over. That's really one of the fastest growing cohorts in Canadian society. The other interesting piece here is that 22% of our labor force is aged 55 to 64. So in other words, really on the cusp of retirement, assuming that 65 is the typical or is the retirement age that people will take. In the US, just sort of as a reference point here, in the United States, total fertility rates now running about 1.7, so below that replacement fertility level, suggesting that slowing of the population growth, and about 17% of the US population is over 65. So not quite as old as the Canadian population, but certainly starting to age because of that low fertility. We can also see the impacts of that aging population in the Canadian context here. We have two, age population pyramids, very sort of common way for providing the composition of a population. So we see two different time periods here, one in 1971, the green, very classic population pyramid shape, although we're starting to see the impact of the end of the baby boom in the very youngest age groups. But by 2021, which is the solid line there, you can see the aging of the population. So those younger cohorts that we saw in 1971, of course, have continued to age, and we see that bulge, in that 55 to 65 or so age range within this group. So there's that bulge that I mentioned in that 55, 65 age group, for example. So where does the aging population intersect with health? And I think, it doesn't take a lot of imagination to think of where that intersection is. Where we're coming from it is we're taking an interest in terms of population mobility. And we start with, that problems with everyday mobility, including walking or driving, are common in older adulthood. And those are going to negatively impact health and social functioning. So if you decrease your mobility, you're less likely to interact, have social interactions, because you're less able to leave your home, less able to travel, for example. And so that's going to impact social functioning and your ability to socialize, and it becomes self-reinforcing, and that lower socialization often leads to lower health status. And we also know that mobility limitations increase with age and often are the first sign of decline. And so changes in mobility do a really good job in terms of predicting disability, in terms of predicting hospitalization, in terms of predicting falls and mortality. We can see this from another perspective. So, we see the health benefits of mobility. And so there's several recent articles that have been published in the mainstream news, for example, that link the benefits of mobility with health benefits. So one here, for example, that came from the New York Times: speeding up your daily walk could have big benefits. Of course, in peer-reviewed journals, prospective associations of daily step counts and intensity with cancer and cardiovascular disease incidence and mortality, all-cause mortality, for example. Another peer-reviewed journal that's looking at or relating step count, so the level of mobility and its intensity, with the onset or the incidence of dementia within a population. So in other words, mobility isn't just physical health, but mental health as well. So oftentimes mobility is really sort of seen as being what could be called the sixth vital sign. Mobility is a key determinant of independent living. I've already noted that it's related to physical health, it's related to cognition and cognitive function, it's related to mental health and well-being. And so, what we're getting at here is that health can best or may best be assessed through physical function and mobility rather than disease. And in fact, changes in mobility may predate or predict disease. And that's, sort of an important piece. So it's really becomes important from our perspective to identify those who are not yet disabled, but maybe at higher risk for mobility decline. So if we can see that, if we can identify those individuals that are not yet disabled, but at risk for mobility decline, then potentially it's possible for a healthcare provider to intervene to minimize or stop that mobility decline, and then obviously enhance some mobility. The added benefit of working in this area is by looking at mobility, we can understand and develop the knowledge base related to their sense of belonging, their independence, freedom within the home, the community, social participation, social network, and social support systems. So, this isn't, when we are thinking about health and mobility, there's these whole other raft of social benefits or social measures that we can capture as part of this work that we're really interested in. So I've been throwing this idea of mobility around quite a bit here. So what do we actually mean of that? And this is, we're working with the definition that's drawn from the International Classification of Functional Disability and Health. And so mobility is moving by changing body position or location, or by transferring from one place to another, by carrying, moving, or manipulating objectives, by walking, running, or climbing, and by using various forms of transportation. So I think, this is really a pretty encompassing measure of mobility. It takes beyond, or moves us beyond, just sort of a very functional approach to that ability to use, say, public transportation, to be able to drive themselves, for example, be able to get from place to place. So it's mobility not just in the home, but outside of the home. That's part of it. The other piece here, so, if we want to try to predict changes in mobility, we want to think about mobility as really a continuum. And part of that is going to reflect how we age and the changes in mobility as we age over time. So, now, if there's no difficulty, there's no mobility limitation. But one of the interesting things that we start to see is that individuals might have what we call preclinical mobility limitation. And this is really where individuals will still report no difficulty and experience no difficulty in their mobility, but they may start to adapt their movement through space, adapt that mobility. So they may be making very subtle changes in terms of how they go about moving through space. Maybe it's a slower pace. Maybe they become more tired more quickly as they move as they engage in mobility. Or they may make other very subtle adjustments in terms of their gait and their behavior, how they get up or sit up and stand up from a seated position, for example. All of those could be changes, and they're reporting they're not necessarily reporting overall change, but they've modified how they go about doing that. If that continues, then we start to get into increasing difficulty in terms of that mobility. So they start to report some mobility limitation, and then you start to get into great deal of difficulty or very unable to move through space. At the one extreme of that continuum. So this brings me to this idea, or to the project that I'm engaged in this McMaster Monitoring My Mobility, or MAC-M3 study. It's a research platform that's based here at McMaster University and McMaster University's Institute of Applied Health Sciences. We have a very large medical research school here and hospital on campus. And so there's this abundance of health-related research. We also are represented by a multidisciplinary team of researchers that are interested in looking at mobility changes due to aging. So the research team draws from occupational therapy, physical therapy, nursing, geography, GIS, economics, kinesiology, business, and some engineering and other teams. So it's this really, truly multidisciplinary team that's bringing their efforts to bear on this. And we're currently in a multi-year project, our cohort study, with 2,000 participants, and they're using wearable technology in order to look at their mobility. And I'll talk more about that wearable technology and what we're doing with it in a few minutes. So the overall aim of the MAC-M3 program is to determine mobility trajectories using that wearable technology. So sensor-based data from this cohort of 2,000 older Canadians, 65 years of older, with different levels of mobility. So some of the participants that we've recruited into the study have no mobility limitations, and some of the participants have varied levels of mobility, from very slight mobility modifications to more evident mobility limitations. You see that Venn diagram that's on the right-hand side of the slide here, and this really represents the different places where we're gathering information. So bottom right-hand corner, what we call hypothetical mobility. This is really self-reported mobility. There's generally a good agreement between an individual's mobility behaviors and ability and how they self-report that mobility, but there's also the potential for bias in terms of over-representing the distance or the amount of space covered during travels. For example, if we're using a trip diary, for example, we may not fully or completely and accurately fill out the information as a self-report information. So, it's one benchmark, one way of looking at travel behavior, but not necessarily the only one. But we are using that self-reported mobility as part of our data capture. We take a look at mobility capacity. So we have an in-person physical assessment at the start of the research project when individuals are first recruited into this. They come onto campus and they're put through a battery of different tests that look at or measure their mobility. And then this third at the top there, this enacted mobility, really looking at their performance in the community. And this is where we're using, or where that smart technology comes into play. Two broad phases to the work. The first phase is the customization and validation of wearable technology so that we can track people across space. And the second phase, that this prospective cohort study where we're using the technology, this validated technology, in order to track people with these comprehensive assessments, that physical piece where they're on campus, and we're measuring various physical attributes, the self-reported piece, and then we're doing that at multiple times across the study, at baseline when they're first recruited into the study, as well as at selected times throughout the 2-year follow-up. We also are, gathering information on health outcomes and healthcare utilization, whether or not they fell or if they report a change in mobility status as they continue to age through the period. I'm really going to talk about phase 1 here and the technology and how or the measures that we're using. We're still very much in phase 2 in the data collection phase yet, doing some preliminary work with some of the data, but we haven't got that far with it. So just in terms of research objectives, we examine differences in how older adults with and without early mobility limitation move within their homes and communities. And we're developing this multi-sensory monitoring infrastructure where we can capture step counts, GPS track, trip distance, so we can get a trip distance and frequency for that population movement. And then track how people with and without early mobility limitations move within their environment. So that prospective cohort study. Okay, so let's get to the sort of that technology piece and how do we want to capture the mobility? Well, we could use a trip diary, very standard way within transportation studies to take a look at individuals' reported movement through space. As I've already mentioned, it's subject to biases, reporting biases, accuracy of reporting, how well people actually complete the diary part of it. So it's subject to some concerns. Smartphones, most of us, and I apologize, clearly I've got some bright sunshine coming into my office this afternoon, so I appear a little bit of dark, and what I just held up there is my smartphone. Most of us carry smartphones on our, and they're with us all of the time. But in terms of trying to capture mobility within a population, it may not be the best because then not everybody's using the same technology, the same platform of technology, may not, or it may exclude individuals that don't have, or would exclude individuals either that have older technology or don't use smartphone technology. I know both my parents and my mother and father-in-law, they can say they have a smartphone. It's just that smartphone is from, or no, let me back that up. They can say they have a mobile phone, but that phone is from really, 1990s or early 2000s technology. It's not a smart phone by any means and wouldn't have that ability to track that individuals across space that we would want to get at. More often than not as well, the phone is actually turned off and unpowered. So it's not a good way to do it. We could use a GPS tracker, again, state-of-the-art, probably gold standard in terms of measuring GPS or capturing location in space. But if we're asking people, the to carry the GPS piece, obviously that gets at the GPS, but it doesn't get at step count. So we're missing part of the information, and if we're missing part of that information, then we're probably asking people to carry two devices, the GPS tracker and a step counter, which then is going to result in, I forgot something at home. The individuals and the participants in the study end up leaving that part of the technology or all of the technology at home and not engaging in it. Smartwatch or other wearable technology, and this is where we've settled in terms of a wearable technology. So we can look at some of the smartwatches that are available on, for purchase now. They're equipped with multiple sensors, including, step count, location, accuracy, so that we can track that physical location. We can look at their activity. So they're going to come with the accelerometer, with step counter, heart rate sensor, location, GPS, activity mode, gyroscope. So it really, this technology really allows us to get at that movement. It provides or can provide continuous data collection, at least over the course of a day, probably, or would need to be recharged overnight so that it can then continue the next day. But the other thing here is that, it's a technology that's intuitive for participants, that we give them the smartwatch, they wear it for the period of the study, say a week, they'll wear it over multiple cycles, as I mentioned, but it's intuitive. And we did some early focus groups with older adults to say, of these different technology pieces, what feels comfortable. And, one of the things that stood out is they were quite comfortable with using a watch. They're quite used to it. We looked at a number of different wearable devices. There's a few of them here. So the Fitbit, for example, we looked at a Garmin smartwatch, and the other technology that you can see here. Problematic, or some of these were problematic in that they didn't completely fulfill the information. So Fitbit, yes, it captures GPS, but it has to be tethered, which means that you've got to keep it connected to smartphone, for example. Other brands like the Garmin don't necessarily provide that information. They don't provide the raw data, or it requires that the data gets transferred to their server before it can be collected. And certainly in the Canadian context, we become concerned, and our ethics review boards become concerned, where we're talking about data that's being stored outside of Canadian borders, whether it's the US, Europe, or anywhere else. We're concerned about access to that data, or who might have access to the data when it's beyond our borders. Other brands didn't have GPS, or only supplied it with tethered GPS, or just simply didn't have enough battery life associated with collecting the GPS data. So it wouldn't be able to keep up. So none of the devices had similar accuracy or the features that we want that surpass the TicWatch Pro. That's ultimately where we landed in terms of the technology that we used. So TicWatch, it's acceptable to users. It's customizable so that we can go in and work with the programming. It's an Android software that we can adjust or reprogram. We can access the raw data. It's stored on the watch. When the watch is returned to us, then we download that data. We've tweaked it so that we can get 10+ hours of GPS data collection over the course of a day. So really capturing the majority of the day when individuals would be moving around their home and outside of the home. It requires to be recharged at night. But we've again seen that individuals that are participating in the study do plug or charge their phone overnight. And then we've developed custom desktop PC companions for the setup and the download associated with it. So when they're returned, we have that customizable software that we're working with. Of course, we needed to validate this technology. So where did we validate it? We did a validation study where we had 32 older adult participants that wore the tick watch along with carrying a GPS, Q-Stars GPS, and an actigraph. So actigraph is sort of the gold standard in terms of step counting. We didn't want to use a step counter that basically came out of the box of cereal or very cheap step count. So we wanted to make sure that it was accurate, and the step or the actigraph is recognized within the academic literature as having the accuracy that is required. So the participants in this validation study were wearing the tick watch, the actigraph, carrying the Q-Stars for the GPS piece. They also used a travel diary so that we could start to look at and overlay, the data that we're actually capturing with where individuals were going. All of this, of course, has gone through our research ethics office here. And what did we, so how did we do? We did have to make some tweaking. So, the Q-Stars, that GPS collector, it's collecting data every 5 seconds. We needed to, with the tick watch, go to about every 20 seconds. That's one way that we were able to extend the battery life. But we still got really good results. So, the tick watch and the GPS, the Q-Stars, had really good agreement in terms of measurement of life space area, and I'll come back to that in a few minutes. We had very strong similarity in terms of trip duration between the two devices. They were really good in terms of capturing the trip mode, because one of the concerns would be, is an individual walking? Are they on a bus? Are they in a car, for example? Trying to distinguish that within the data and the assumptions that we need to make there. And then, just in terms of, we also looked at the reported wear time in the diary versus what we were capturing in the watch, and we saw good validation or agreement there. There's also good agreement between the tick watch and the actigraph in terms of the physical activity intensity and the step counts that we were capturing. The one piece where was the tick watch and the actigraph weren't as good is in terms of the body posture. So if an individual was lying down versus sitting, tick watch didn't do as good of a job in terms of capturing that information. We could also turn to some of the literature to say that individuals, that this technology was acceptable. We had already talked to individuals to say, yes, wearing a watch works well for them. So the watch was acceptable, but then elsewhere in the literature, we saw that, yes, older adults, are able to, use these devices to collect the data. One study, Rosenberg et al., the participants are using 2 devices. They had good compliance with that. Another study here, again, older adults, and they had good uptake of the technology, although recruiting into the study was a challenge. And that's, to be honest, something where we've also in part struggled in terms of getting participants, and certainly a diversity of participants to reflect, sort of the broader society. There tends to be, like in many studies, you have a group of people that are eager, energetic, want to participate, generally healthy, probably with less or fewer mobility limitations, and it's harder to recruit, maybe somewhat older or individuals with mobility limitations or some mobility limitations. It can be harder to recruit more vulnerable populations and individuals of color to the work. So this is where the geography really starts to come into this and some of the data. So what are we using the GPS data for? Although this also brings with it its own challenges. So of course, GPS mobility or tracking, we can take a look at where individuals are traveling to and from. We can capture maximum distance from home. We can capture the life space and some other indicators. And I'll just quickly pull some of these apart. So maximum distance from home, and in part, what you're seeing here is both the Q stars and the tick watch. So, the Q stars has that solid line, or what's essentially a solid line, because it's capturing, it's pinging off of the cell towers on a much more frequent basis, that every 5 seconds versus every 20 seconds that we get with the tick watch in the red on the right-hand side of the slide here. But strong agreement, as I mentioned, between the two. So we can capture, we can use that as a measure of, the furthest distance from home that an individual or made with that. We see that both the furthest distance, or we can tell from the literature, that both furthest distance from home as well as the life space indicator that I'll get to in the next slide, are good indicators, or one of income. So, higher incomes, higher socioeconomic status tends to have a larger life space or further distance from home. But also importantly, cognition, that as our ability to navigate through space decreases with age, that maximum distance and our life space is going to start to shrink, get smaller, because we simply can't navigate, or we lack the resources and the mobility tools in order to navigate and move across space. We may lose our driver's license. We may not be able to use public transit, for example, as part of that. Here's that life space area. So it's in part reflective of the maximum distance from the house. But again, it's a way of capturing the total space that an individual moves through. Larger spaces are going to be, again, associated with greater cognition, higher socioeconomic status, and so on. Again, strong agreement between the two devices. So some other trip-related measures. Based upon the use of the smartwatch, we'll get the number of trips per hour or per day. So, for example, the number of times an individual left and then returned to the house, how long that trip was, the total trip length, and we're able to ascertain whether or the trip mode, whether it was walking, in a car, in a bike, or anything like that. So we can see these and distinguish these different types of trips. And the image that you're seeing here, for example, the blue dots represent the trip outbound to the grocery store, and then the yellow is a trip back home. So in this case, the individual used the same routing with the stop at the grocery store along the way. But we would also be able to, if the individual is engaged in trip chaining, so maybe multiple stops, we would see where those stops were with the data, and then be able to capture that. So why use that? Why do we go to all of this trouble to capture that? Well, on this location data. So, we're getting or using this GPS data to reveal, the space that individuals move through, the timing of those moves, whether it's active movement, so, engagement, say, in active transportation, active mobility, or whether it's more passive, the attributes of the spaces that they move through, and then that life space. And as I already mentioned, life spaces is correlated with income, the cognition of an individual, physical ability, health, walkability, and vehicle ownership. So, what we hope or what we expect is a more complete vision of mobility. Now, as we've got further into this, and I'll talk about this here, with this prospective cohort study that we're engaged in, this gives you a sense of what we're trying to do. So we will follow, or are following, individuals over a 2-year period. That baseline visit, 12 months and 24 months, where they're on campus, we're doing a physical assessment of their health, And then they're also wearing the tick watch, the smartwatch, every 4 months for 10 consecutive days at a time. So that watch is going out back and forth between, the research hub and the participant multiple times over that period. So really, we're starting to gather as well, not just data associated with mobility at a particular point in time, but how or whether or not we hope to see whether or not that mobility changes as the individual ages over 2 years. Do we start to see some of those subtle differences, that maybe they're not traveling as far, their gait speed has slowed, for example, making fewer trips over time is what we're trying, or what we'll be looking for. Now, granted, this is a huge amount of data when you've got 2,000 individuals reporting, providing data, 10 days, for 10 days, 10 consecutive days measured every 4 months over that 2-year period. And we're capturing that data. It's not over a period of 24 hours, roughly 10 to 12 hours during the period that they're wearing the watch during the day before they put it away and charge for the night. It's a huge amount of data that we're dealing with. And so in part, the challenge now is how to work through this amount of data and put it to use. We also have to, carve out or make some assumptions with some of this information. So, think of the situation where, over a 10-day period, most of the travel, most of the behavior is in or associated with the location of the home, the residential location. But maybe at some point they drive from Hamilton to Toronto, which is, roughly 40-mile distance, or Hamilton to Ottawa, a 6-hour drive. Or maybe they have a seasonal property that they're driving to and engaging with. The question is, do we count that as life space? Or are those individual one-off? Or if somebody goes away for vacation and they're wearing the tick watch, at that particular time. How do we deal with that sort of information? And what's the farthest distance from the home? There's a difference between, an individual that's engaged in their daily behavior in the immediate area around their home or city here, versus that person that, yes, traveled to a vacation property, traveled into Toronto for a day, maybe they've gone to the theater or whatever. What is reasonable in terms of capturing the life space? And those are still some of the questions that we're working our way through. Now, we are putting machine learning to work here, and statistics in order to analyze the data, identify the patterns of mobility changes with aging, and then linking that to their reported health outcomes, with ultimately the intention over time is, the ability to create a monitoring tool where, we could conceive that in the future we're using that ML, the machine learning and artificial intelligence in order, if an individual's wearing the technology, to say, hey, something's happening, your gait is changing. So it's that identification piece. If an individual knows that they're making some adjustments to their behavior, remember that preclinical mobility change, then they could talk to their healthcare provider in order to help to manage and potentially, overcome or minimize and delay that early mobility decline. So, longer term space in terms of having no mobility limitations associated with that. So just to wrap up here, we're identifying people early in the mobility trajectory. And this is really the first time that a major research program has done this. So hopefully that understanding that mobility trajectory can be a game changer for preventing and managing late life disability. As I say, that if we can identify early changes in mobility, then we can make adjustments or have individuals adjust their behavior. Maybe it's engagement in strength training, flexibility, or anything like that can help them maintain that mobility. And hopefully we're able to get this sort of rich understanding of the individual mobility and the environments within which people move. Also, it's not on the slide, of course, but the smartwatch as an interesting way of or promising tool for data collection in research, and in order to capture not just location data, but also step data and accelerometry data associated with individual movement. So it's really combining that information into one in what is now a validated platform for capturing this information. Just wrapping up here, and then we can open it up for questions. If you're interested in more information on this study, we've got the web link there, macm3.com. Some of the institutes or the groups that have been funding this group or this research, we're very fortunate here on campus to have funding from the McMaster Institute for Research on Aging, where a private benefactor provided money to the university expressly for research on Canada's aging population through the LaBarge Centre for Mobility and Aging. We have funding from AgeWell, which is a larger pan-Canadian research group, as well as McMaster University's Office of the Provost. You can also get a sense of where some of our co-principal investigators are coming from. Marla Beauchamp is the PI on the project, coming from physiotherapy here at McMaster. But as I mentioned earlier on, we've got researchers and academics from engineering, computer science, geography, and business, amongst some other co-investigators and different areas across campus. So I'm going to stop there and open it up for questions and comments. Thank you very much.
Thank you, Professor Newbold gave a great presentation about how to use this wearable technology to assess older adults' mobility and help improve their mobility within home and communities. So currently we open to the questions. So, okay, one, yeah, you can just,
okay, yeah, can everyone hear me?
Yep.
Yeah, okay, yeah. Thank you very much, Dr. Newbold, for your fascinating presentation. And I'm actually, I have to say, my research is not in GIS per se, it's on migration and population. So I find this research especially actually useful for developing my future research direction. I actually do have a question. It's more on the social science side. This is a large project. You have 2,000. You have to cooperate with 2,000 human subjects, and with a time span of 2 years. So I'm wondering, how many? What is the completion rate, or how many of them actually couldn't, for example, take 10 exact consecutive days every 4 months? If we have incomplete data, how you actually deal with them?
Yeah, really good question. So I don't have the information handy right now. I'd be able to dig it out, but we've actually got pretty good completion data. There were some, there's a number of people that have dropped out for various reasons as they've gone from, say, one period with the tick watch to the next period, for example. Mm-hmm. But the compliance in terms of when they're wearing the tick watch has been really good. We're getting, I won't say, certainly not full information, but it's generally pretty good. There are cases, yes, they forget to wear it, or the technology, we've had cases where technology is broken, it's lost, left behind, that sort of thing. But overall, I'd say that we've got some pretty good compliance with it. And that, it was certainly one of the concerns that we had going in to this. So how good would that be? I guess sort of a related comment is, we were concerned, would people return the technology at the end of that 10 days?
Oh.
For example, so when we mail the technology out, the diary and the tick watch and the recharger out, we also provide a return envelope or package, and it's sent by courier, so that at the end of it, they just have to put everything back into the box, put it in the mail, and it gets returned to us. But even then, we sometimes we get the tick watch back, but not the charging cable.
Yeah.
So we have had some additional expenses in terms of needing to replenish our technology side. But it's a small group of people and students that we have that are actually sort of getting the materials in and out on an ongoing basis, because it's cycled so that not everybody is being measured at the same time. It's a rolling sample.
Okay. Yeah. Thank you.
So it's very interesting you mentioned just now, based on the mobility limitations, mentioned one is like pre-clinic mobility. So I'm wondering, like for the your conclusion identify the patterns is also identifying these pre-clinic mobility or not, because it seems for the health intervention is more early is better intervention. So if you can identify this pattern, then can have more activity intervention.
That's the hope, that we'll be able to use the machine learning and the artificial intelligence to sift through the data and understand capture some of those subtle changes in terms of gait, speed, length of stride. Even if you take a look at this digresses a little bit, but your smartphone, at least Apple, I'm not sure about Android technology, but if you take a look at the health data, you get a variety of different indicators on there. The percent of time that you have one foot on the ground when you're walking, the gait length, the length between your footsteps, the speed, things like that. So we're collecting that same sort of information, and that's where, when we apply our machine learning to the data, if we start, we're hoping that we'll start to see some of those subtle changes, that preclinical change in mobility behavior, and that's where then we could say intervene individuals. And you're exactly right. The sooner we can intervene in that change in mobility, then the thinking is or the expectation is that we'll be able to improve people's mobility over a longer period of time and keep that mobility up.
Yeah. And the thing is about like the study group is older adult. So it seems that there is perception is that the older adult or senior persons, they are not good at this technology as like the young people. So based on your studies or research, how you see what we saw, like the adult, they can be technology savvy in terms of actually they have rich life experience, if they can give more information or other help may actually help them to use the technology to improve the mobility?
Yeah, that again, really good question. So I guess to answer the first part of your question there, and sort of the recognition or the use of technology, I guess there's different ways of answering that. So one, with the TicWatch, it's very simple adoption. I mentioned in the talk that people were familiar, comfortable with the form of a watch. They've probably worn a watch all their life. So it's just putting a different watch on in the morning. And there's nothing else that they need to do with it. They don't need to touch buttons. And in fact, there's one button on the watch that we secured so that they couldn't sort of push it into a programming mode and avoid that. It's very simple. Put it on. That's all they need to do. Put it on. At the end of the day, take it off, charge it. There's nothing else that they need to do with that. We're not, the trip diary, or I guess also, we give an instruction period. So the first time when they're recruited to the project, we work with them that first time that we see them, take them through the technology and make sure they're comfortable with the technology, that they don't have any problems with it. And what we've observed too, as we've recruited people to it, there's a really wide range of technological update. Some don't use a lot of technology, but most of them do use technology and quite extensively, including fitness apps on their smartphone. So maybe Peloton, for example, they'll have that or other technology on their phone that is used as an incentive or something to encourage, something to track the exercise that they do. So bottom line, a range, but a lot of older adults are using technology and using technology in a very comfortable way.
So then for this study, you do have their profile has this information about their technology levels.
Yeah, that's just to a limited extent, but it is something that we capture early on in the study.
And do you see the association between if they have a higher technology level, then they have a better mobility?
No, and I guess we haven't looked at that directly yet. To just ask, as a starting point, if they're, high technology users, do they have better health or better mobility? We haven't looked at that at this time.
I see. So then it's interesting to look at. You mentioned that you also look at the life space areas in terms of different factors like income, cognition, like physical activities. So could you give more details about these different how these different factors actually affect their mobility?
Yeah, so something like, well, both life space and maximum distance from home, certainly drawing from the existing literature, what we see is that both are correlated with a series of effects. So one, better health. Individuals in better health are going to have a larger life space, and that could also represented in terms of larger social networks, for example, larger space over which they're engaging in behavior. That behavior could be shopping, it could be socialization, recreation, anything like that. That also is in part reflective of income. So if I use the example of an individual, if income is a proxy for transportation mode, the individual that is reliant on public transit is more likely to have a small life space area because they're limited from a time and cost perspective, or just the how far that transit system extends, they're limited by the physical geography of the transit system, their reliance on it, versus somebody with their own personal automobile. They'll have a larger life space area because they can maneuver beyond sort of that space, and easier at their will, when they want to do that. But that cognition piece, it goes to, or gets at how well they can personally navigate through space and on their own. So an individual that is having difficulty with cognition, they're having difficulty, say, with directions, wayfinding, memory of locations, their life space is going to be much smaller, to the point where essentially there's no life space. It's confined to immediately to their specific location, their residential location in space. The final piece there, I guess, is physical health. So if an individual is already dealing with some sort of mobility location, say they're dependent or use a mobility aid like a cane or a walker or a wheelchair, they will typically have smaller life spaces and maximum distances as well, just reflecting the difficulty and the barriers that they face in terms of moving through space.
I see. Yeah, that makes sense. So in terms of just now you mentioned like there are difficulty for the mobility. I think you also mentioned in your slides is one aspect is the disability. So, and also you mentioned that you have for different aspects of mobility to look at mobilities from like inactive and also inactive mobility is mainly like the performance in the community. Then have for the mobility capacity, so it's more like in person, and then has the hypothetical self-report. So I'm wondering this, since it's mentioned like the performance in the community, so is this is compared to at home in person at home, or it's like how actually for this mobility difference like among these different contexts?
So
so like for the mobility disability is different at home or at a community?
I think it's more that the disability could limit how far or how much they engage in the community. So if they're reliant on a mobility aid, moving about is more difficult. They may make fewer trips of shorter distance or shorter duration because of that. So ultimately it's that smaller life space piece that goes with it. I think that's what you're asking, as opposed to somebody that doesn't have or isn't reliant on a mobility aid. They're not facing those barriers to moving.
Yeah,
a
exactly.
barrier could be just as it's getting on a bus or getting into their personal car if that's difficult for them to make that or engage in that action. One thing I didn't mention during the talk is that the participants that we have in the study, so they're either no mobility limitations or limited, minor mobility limitations. We're not capturing people that have severe mobility limitations. We're also not including individuals that live in any form of retirement or group home.
But your study you can like distinguish like the minor and the major.
Yes.
Oh, okay.
Yeah. So part of that's going to be revealed either through self-reporting or during those in-person site assessments when people come onto campus and we have lab space where, we put them through various tests. There's like a timed up and go test, for example, where they're seated and then they need to stand. How long does that take an individual? And we can observe them and see, if they're using or how they're moving. We look at, the amount of time that it takes to cover, the distance of 100 feet, for example, to get an impression of their overall walking speed. Other tests, how long their step is, their flexibility, their strength, we're capturing through that. So that gives us a very precise measure of their physical abilities at the very start of the study, and whether or not they're dealing with some minor limitations or in terms of their mobility.
I see. So since for this, it seems for these studies, you use 2 devices. So then you mentioned it's have for these 2, it's a multi sensory monitoring infrastructure. Is and owning these 2 devices is combined with other other data sources like a diary or other sources. So I'm wondering how difficult for your study to combine different these data sources, especially for the sensors data sources, and how you see currently actually for people using these wearable technologies. Actually, I think the large challenge is to integrate different sensors data sources, data from different sources, since the standards or it's the formats, it's not that standard, or it's different.
Yeah, so the participants are only using one piece of technology, just the smartwatch. We were only looking at like the smartwatch and the GPS piece and the actigraph in the validation, because we wanted to see, does the TicWatch capture step count accurately? How well does it capture GPS? So though that was that baseline. So the actual participants in that prospective cohort study are just using the one piece of technology that's capturing, the steps, the gait, the distance, the GPS track, things like that. They are doing a diary, but it's the challenge that we face again is just the amount of data during the validation exercise. We were using that to try to test our TicWatch to capture, okay, what type of movement? Are they walking? Are they biking? Are they in a car, for example? We have used to date anyways, we have relied less on the diaries that the participants are giving us as compared to just the TicWatch information.
Oh, okay. That's how actually we still need the diary to actually have more complete records of physical activities.
Yeah, and it in some ways it is duplicating the information just in a very different form. But what it does give us is, was it a trip associated with socialization, going out to a restaurant, visiting friends, or was it a trip for healthcare and going to a doctor or a dentist, or was it, a trip to the gym, or anything like that? That's the advantage of keeping that trip diary, because otherwise we see tracks and, the hope is that as we start to layer the information onto a map, so we get the GPS track and we see that they stopped, then we can take a look at the stop and say, okay, well, what's there? But even then, that's challenging, because if they stop in a power center, or what we call a power center, so a large outdoor mall or shopping area, maybe there's at that one location, you have a Walmart, you have a bank, you have a restaurant, you have, or two, you've got an optician, hair cutting place, anything like that. So we know that they stopped at that shopping center. Where did they go? And that's where we can go back to the travel diary. We could make some guesses, but obviously in a big center like that, it's not going to work. In fact, there's no sense or accuracy in guessing when they stop at a shopping center as to where they went. We know how long they were there, but we don't know where they went or if they did multiple stops in that location. Now, in another case, it might be very simple. They stopped at a particular, we can see, based upon their GPS track, they stopped at a specific store. That's easy. Most of the time it's not.
Yeah, sometimes. So then how you see actually it may, for this location, information may integrate with the outer crowded source information.
Yeah. It's difficult, that we've got, and you made the comment that we've got essentially two different data sources. One is that self-reported piece, and then we've got to integrate the time with the stop that we see in the GPS track. So there's a lot of little sort of detail with it, but even just working through the sheer amount of data, the computers are kept busy.
Yeah, it's already a large amount of
exactly. Yeah.
So in terms of just now you mentioned for the they are activity purpose actually still need a diary. So I'm wondering, today is Eastern and Eastern South Asian Mid-Autumn Festival, and since you are working on immigration, so also do a lot of immigration work. So I was wondering, did you see this mobility actually is distinguish different groups in terms of culture and religion?
Yeah, we haven't been able to dig into that yet, but part of the problem there is how representative our sample is. So we've got a large sample, but it goes to my earlier comment in terms of the ability to recruit particular groups. So we see, and we've tried to work around this or extend the recruitment efforts, but the sample, it tends to be predominantly white, older adults, with much smaller shares or representation from other groups within the city. And I think in part it's the nature of recruiting volunteers from the population to do to participate in this type of work.
Yeah, let's actually for the sample for these studies, it's represent a certain group, or it's still it is a diverse for this study population.
Yeah, it wouldn't reflect the diversity of the city, for example, in terms of the different ethnic or racial groups within the city. We have representation, but it's not, if just using a very simple example, if 70% of Hamilton's population is white, 30% or 15% is black, and 15% is Asian, our sample is far more, I'm guessing, I'm making numbers up here, but it's a much larger proportion of white participants than the other groups.
Okay, I see. Thank you so much to give this presentation. We learned a lot from your talk about how actually currently wearable technologies can help us assess adult mobilities and improve that. Thank you so much. We give the applause.
Thank you for the opportunity.
Thank you.
Thank you, Dr. Newbold.
Yeah, you're welcome. Have a great weekend, everybody.
You too. Have a great weekend.
Bye now.
Bye.